We're going to move on to our next session, and I'm going to hand it off to Aisha Akhtar, who is with the Epilepsy Foundation of the Greater Chicago, to introduce our next session.
Thanks, Russ. Hi, everyone. Good evening. Thank you for joining. For those of you who have just joined, welcome to this amazing conference on rare epilepsy. So I'm the Director of Education for the Epilepsy Foundation of Greater Chicago. And I guess this is a perfect segue into our next panel, talking about what to do when nothing else works. So our next session is actually titled, No Stone Unturned, What to Try When Nothing Has Worked. So this panel of speakers includes Dr. David Burdette, an epileptologist from Spectrum Health in Grand Rapids, Michigan. He will speak for 20 minutes. And then we have Dr. Peter Warnke, a neurosurgeon and researcher from the University of Chicago Medicine, who will also speak for about 20 minutes, and each of them will go through their slides. And then we have a parent who will like to share her story with you. Her name is Kelsey. Together, everyone is going to discuss complementary and experimental therapies, novel applications of existing therapies, and also approaches on managing drug-resistant epilepsy. So now I would like to turn it over to Dr. Burdette. And a reminder, please keep adding your questions in the chat. Thank you.
Can you see my screen?
Yep.
Yes.
Beautiful. Well, it is my pleasure to join you this evening. Incredible presentation by Dr. Dixon Salazar. That it was an inspiring message of hope, one might say. And to piggyback on that, when we are confronted with the rarest of epilepsies, I like to think back to the Churchillian quote from 1941, where in talking to a group of school children, he said, never give in, never give in, never, 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 in nothing great or small, large or petty, never give in, except convictions of honor and good sense. And I think that Dr. Dixon Salazar started this conversation tonight from a good sense perspective. So what I would like to do is to speak towards some treatment options, some approaches that one may use in situations that perhaps at times may seem hopeless, when in fact, if we do nothing, our loved one, the persons for which we care who have the rarest of epilepsies have a 0% chance of doing better. But if we do something, then we have a fighting chance of making a difference. We do, however, need to be rational, use science as best we can, science still defining what those options are, to make those choices. And in making choices after the standard treatments have failed, I think a common way to go is to let's go back to the basics. And the basics include the notion of what is a seizure. As we all know, a seizure comes from a network of neurons, a network of populations of neurons. And I think on Dr. Dixon Salazar's slides, she referenced this network notion, where we have a population of neurons exciting another population, another population, another population, dot, 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 coming back to the first one. So this collective population may fire of its own accord and cause a seizure. This is not firing in a vacuum. Here, we've got perhaps a temporal neocortical seizure. It gets going, it tries to entrain the firing of its neighbors, and the seizure may spread in a certain fashion, and hence we get a seizure that may fall on a spectrum of severity. We have other individuals, and this is more commonly represented in our rare epilepsies designation, individuals who may have multiple areas, such as with Lennox-Gastaut syndrome, that form together to involve large areas of the brain, both sides of the brain, to cause seizures. If we look at the upper right-hand corner, this is a representation of a seminal study that was done about 21 years ago. And it's a Scottish study where they had available to them the medications, anti-seizure medications that we had at that time in the US. And they found that roughly little over 2/3 of patients, or little over 1/3 of patients, despite our best efforts with combinations of medications, systemic use, the systematic use of medications, these patients continue to have seizures. So if a person has tried 2 or 3 reasonable anti-seizure medications, either alone or at least one combination, and they continue to have seizures, then already they are headed toward that rare designation of refractory seizures. And there are a few steps that one will typically want to pursue in this situation. First is, let's take a step back. Is this epilepsy? Perhaps this individual has a mimicker of epilepsy, a sleep disorder, fainting episodes or syncopal episodes that are being misinterpreted as seizures. Perhaps this person has a certain syndromic form of epilepsy. I believe Dr. Dixon Salazar mentioned the SCN1A mutation and associated Dravet syndrome. We know that certain very potentially effective anti-seizure medications for some forms of epilepsy actually exacerbate Dravet syndrome associated seizures. So perhaps an individual is not on the right medication. How we're going to figure this out is to pursue inpatient video EEG monitoring or outpatient video EEG monitoring. And this is often achieved or obtained through an epilepsy center. The National Association of Epilepsy Centers has level 3 and 4 designations. These are the highest designations, and many individuals with rare forms of epilepsy will appropriately see physicians, see epilepsy specialists and other providers at these epilepsy centers. So with this as a backdrop, I'd like to present 3 cases, 3 individuals who had rare forms of epilepsy that different approaches were taken with success. This isn't going, we can't extrapolate from this to everyone, but it is to further this message of hope that if we continue to strive for freedom from seizures, or at least a significant reduction in seizures, as we heard Savannah achieved with verapamil, then we are getting ahead of the game. So this is a 27-year-old individual who had refractory seizures as a young child. He had infantile spasms. We heard mention of West syndrome, often going to Lennox-Gastaut syndrome. He fortunately did not. So he had a typical treatment for his West syndrome in the form of ACTH, and then went seizure-free for a period of time. Unfortunately, at the age of 12 years, his seizures recurred. He does have an underlying, rather rare brain abnormality called polymicrogyria. We are all aware of the gyri, those grooves, and the anatomical appearance of the brain that gives it its unique appearance. And these gyri and sulci occasionally, in some individuals, may be too few, in which case they may have pachygyria, so too large of gyri, or they may be too many, in which case one may have multiple, micro, small gyri. And when someone has polymicrogyria, there's an inherent fragility to those neurons, and it predisposes that individual to developing epilepsy. And alas, epilepsy appeared at the age of 12 years, and a rather devastating epilepsy, where every 2 weeks would have seizure clusters, frequent isolated seizures, and despite multiple trials of multiple anti-seizure medications, there was no success. Dr. Dixon Salazar also mentioned a phenomenon of sudden unexpected death in epilepsy. Individuals who have frequent uncontrolled seizures are at risk for this most scary of phenomena. So in order to pursue other treatments, he underwent stereotactic EEG monitoring. So implantation in a stereotactic fashion of depth electrodes in strategic areas of the brain to determine what portion or portions of the brain were producing seizures. And what we found was the majority of the seizures were coming from the underside of the right temporal lobe, with fairly frequent independent seizures coming from more toward the back of the right hemisphere, and some others from a deep part of the brain called the insula. He underwent resection of that most active area, did well initially, but inexorably seizures returned, fortunately at a lesser frequency, but nevertheless not where we wanted to be. So it's back to the drawing board. What can we do to make a more substantive improvement? And our thoughts turned to responsive neurostimulation. Dr. Dixon Salazar mentioned 2 forms of what we call neuromodulation, where a device is implanted, and this device is designed to introduce judicious amounts of current into the brain, which, as she referenced, works by electrical activity, and to have one of 2 effects, actually 2 effects. One of those effects is an acute disruptive effect on seizures. A second is to train the brain not to have seizures, a long-term neuromodulatory effect. She had mentioned DBS and VNS. He had an RNS, and was the second person in the US to have a deep nucleus targeted deep in a part of the brain called the thalamus. And since that time, he has had a greater than 90% reduction in seizures. So this would be using an existing technology to target an atypical target within the brain. Another approach, another example, this is an individual, a 43-year-old individual who was previously healthy. Over a 3 to 4 week period of time, developed progressive psychological and psychiatric issues. Over a 1 week toward the end of that 3 to 4 week period, started to have rhythmic jerks at the head and extremities, and then started to convulse. Was seen at a hospital where the convulsions were stopped, although that rhythmic jerking continued, and EEG was obtained. And on the right, you see this EEG on the top panel without the person being on a paralytic agent, and in the lower panel with it. And you see this undulating appearance, and over that, this little thickness, and we call those brushes, if you will. And this is a pattern that is well described called extreme delta brushes, and is seen in a phenomenon, an autoimmune phenomenon called anti-NMDA encephalitis. So the NMDA receptor is one of those brain receptors, one of those brain proteins that is responsible for generating electrical activity in the brain. So I put back up here my little neural network, and you see my series of pluses here. So every nerve cell that is connected with a plus is exciting another nerve cell. Much of that excitation is driven by NMDA receptors. And some of you may be aware of a notion that magnesium can be used to have the mildest of anti-seizure properties. This is driven through its effects at the NMDA receptor. And when someone has a tumor, perhaps, and the most common associated tumor is an ovarian teratoma. Teratoma is a benign tumor that when it occurs in the ovary, may cause the body to produce these antibodies against the NMDA receptor, which forces it to be overactive and produces psychiatric issues, movement disorders, and seizures. So this tumor was removed, and this individual did well from an overt seizure perspective, but continued to have twitches and was not waking up. Ultimately was transferred to our center for continuous EEG monitoring, and it turned out that those twitches were in fact seizures. And trying different medications, we hit upon ketamine, which is an anesthetic that specifically targets the NMDA receptor, and that was able to stop these seizures. Alas, every time we would try to reduce the ketamine, the seizures would return. So ultimately, she was given an aggressive load of a drug called perampanel. Perampanel works against an AMPA receptor, which is linked to this NMDA receptor. And she was given 3 times the maximal FDA approved dose. But with this dose, we were able to suppress that twitching, suppress recurrence of seizures, and gradually over the span of 60 minutes, so not too gradually, we were able to get her off of ketamine. But now it has been a long road to hoe, as they would say. She had a long recovery ahead of her, but she has gradually returned to meaningful responsiveness, regained the ability to interact and to ambulate. Another individual is, and I have to give special thanks to Dr. Fain, a pediatric epileptologist, and Dr. Adams, a medical geneticist at Helen DeVos Children's Hospital, who educated me on this case and allowed me to use it. This was a young gal, an infant, who at the age of 2 months presented with new onset of seizures. And these seizures were multifocal, arising from each hemisphere, and continued despite reasonable trials of typical drugs. If you look at the 2 panels here of EEG, in the upper panel, you will see the red colored lines look very rhythmical. In this individual, red is for right, and this is a right-sided temporal seizure. Later on in the study, in the blue lines, we see again excessively rhythmical activity and independent seizure coming from the left. They did an extensive evaluation, and included in that was a test that Dr. Dixon Salazar mentioned, whole exome sequencing. And this revealed a couple of variants that have not heretofore been associated with seizures, but clearly stood out, perhaps in an analogous fashion to Savannah's issue with L-type calcium channels. And this abnormality is one that is linked to a couple of B vitamins. Specifically, she was treated in addition to her anti-seizure medications, which frankly were not working, with a form of folic acid, vitamin B9, that is the biologically active form of it, so methylfolate, as well as vitamin B12. And with that, she had a gradual reduction in and ultimately cessation of seizures. After 6 months, I think it was 6 months, Dr. Fain told me, but within less than a year, her anti-seizure medications were weaned. She remained seizure-free on folate and B12, and she has developed largely normally, although she does have some mild speech delay. So an example of similarly with Dr. Dixon Salazar's daughter, of use of whole exome sequencing to define a treatment paradigm that does not necessarily include anti-seizure medications. My last, I had said I was going to do 3 cases. Alas, I'm doing 4 because I love talking about this stuff, is an 18-year-old who has a history of panic attacks dating back to when she was 2 years of age. Her mother recollects that she would suddenly get this look of just utter fear and anxiety on her face and start running. Her eyes would be wide open, her heart racing, and this would happen 10 times a day. She was started on a daily benzodiazepine for the treatment of these, and the events improved. In fact, they resolved for about 3 years. Alas, they recurred when she was 5 years of age. She was, over the ensuing 13 years, treated with numerous unrecalled, meaning her mother doesn't recollect every one of them, but a number of anti-anxiety medications, a number of antipsychotic medications. And although they might take the edge off these events, they were largely unhelpful. She had severe clusters in 2013, resulting in a psychiatric hospitalization, and another one in 2015. We ended up evaluating her not initially, but in 2016, June of that year, she was admitted to get medical clearance before she was admitted to another psychiatric institution. And an astute psychiatrist said, these are very stereotyped anxiety spells, and most 2-year-olds don't have panic attacks. Could these be seizures? And in fact, she was hooked up to EEG. That EEG monitoring can be invaluable in these rarest of epilepsy cases. And lo and behold, it turned out that all of these panic attacks were, in fact, frontal lobe seizures. They were arising from somewhere in the midline, so it wasn't 100% sure which frontal lobe and which side. So she was tried on various anti-seizure medications, and she would have what I would call a honeymoon effect. She would have an initial improvement, and then inexorably the seizures would return. We would try a new medication, initial improvement, seizures returned. So after trials of 3 medications and at least 1 combination, it was clear she was medically refractory. She underwent a pre-surgical evaluation, which revealed the seizures were coming from her right frontal lobe. So we pursued intracranial monitoring with the electrodes focusing on that right frontal lobe, some on the left, and we recorded seizures. You can see that rhythmic activity coming in. Ultimately, we were able to localize the seizures toward the middle of that right frontal lobe, and instead of having a craniotomy, her whole side of her skull opened up and a surgeon go in, a small defect was made in the skull, a laser introduced, and you can see here on the right where that laser ablation occurred. And she is fortunately now seizure-free. And as you would expect, since the psychological events were of epileptic origin, free of those as well. So I will end with a quote from a British physicist, and that is, if the human brain were so simple that we could understand it, we would be so simple that we couldn't. Thankfully, the complexity of the brain is so great that we are not simple, and neither, therefore, is the task of understanding it. So, furthering or continuing on Dr. Salazar's insightful and inspiring talk of a moment ago, I would like to observe that having done epilepsy for the past 30 years, there are tools at our disposal on the genetic end, on the treatment end, that I didn't have available 5 years ago, and tools 5 years ago that we didn't have 5 years before that. So ultimately, this is a message of hope. And with that, I will turn this back over to Aisha.
Thank you. Thank you, Dr. Burdette. That's definitely an uplifting and inspiring quote. Thank you for sharing that with us. That's a great segue to Dr. Warnke. I will turn it over to you. Please share your screen.
Thank you so much. Can you see my screen?
Not yet.
Okay, good. Thank you so much for having me. So I'll talk a little bit about novel approaches to epilepsy surgery. A lot about these novel approaches actually pertain to rare epilepsies, and others to not so rare epilepsies, but epilepsies that were regarded as not amenable to surgery in the past. And actually the technology and the insights into neurobiology clearly make this possible now. So these are my disclosures. What I will start with these giants in the field, while the
Dr. Warnke, sorry, we can't see your screen.
Okay, let me see.
There we go.
Okay, we don't. There we go. Let me get my. Okay, let me go to presentation. Okay, good. So I've told you I'll talk about the novel approaches and the neurobiological approaches we've taken. This is a little tour de force for the last 5 years. These are my disclosures. So we have these strong opinions in epilepsy surgery with Wilder Penfield, who actually defined this as a volume disease, basically pinning it down to this simple approach: the more you take out, the better it is. The opposite was in Paris, Jean Talleyrand, who said, no, it's always a focal disease and you just can't find the focus, but do as little as possible, find the focus, and that's it. And Lars Lexell, who invented the gamma knife, said, treat the focus first, which is probably the Solomonic view, because most of generalized epilepsies that are amenable to surgery start as focal epilepsies. And if we can find it first, we can stop the process of evolution and actually have a reasonable chance to make the patient seizure-free. So I'll go relatively systematically through very focal epilepsy, surgical approaches we've developed in the last 5 years for this, and go to more generalized epilepsies. And it's in a systematic fashion. I'll show you the cases, I'll show you the data, and you'll see the images pre and post, and then you'll see underneath always the actual video. I'm mainly talking about laser ablations, but also about neuromodulation of the actual surgery whilst it takes place. So one of the things, and I completely agree with Dr. Burdette, is that surface EEG can be quite misleading, even if you use high resolution EEG, like in this picture, where actually this is actually the recording from, for those who know, great neuroscientist Wolf Singer from the Max Planck Institute, who posed for this picture. You cannot really say whether this is focal or not focal, with some exceptions, because you have a lot of volume conduction and seizure projection. So this is why we've moved, before we declare something definitely not treatable and generalized, to two things. Number one, stereo EEG, invented by Jean Talleyrand, whom I mentioned before. And we use very sophisticated source localization and or magnetoencephalography. And this is a typical example where we actually put in a lot of stereo EEG electrodes and then moved this by analyzing the EEG in a three-dimensional fashion and inverse correlation to find the actual seizure focus. And this is one of our recent patients who had a very complex semiology, as you can judge from where the seizures are reaching into the SMA, who then had a very successful resection based on the actual source localization. And this is very, very critical when you get into areas which are highly functional. And this is a classic case where you can see that there's an epileptic focus. It's a very small focal cortical dysplasia in the supplemental motor area. If you would perform surgery there, you almost inevitably would have a temporary, not a permanent deficit. And what you can see on the right here is we basically, using depth electrodes, encircled this focus, made absolutely sure we knew where the borders are electrophysiologically, and then actually stimulated through one of those channels and evoked a seizure and looked what happens if we ablate. And then we performed a laser ablation, which you can see in the center. And this is the typical course that you can see here. Pre-surgery, you see this is a very small, tiny focal cortical dysplasia. This is the laser ablation, which always causes, because you open the blood-brain barrier, a little bit of edema. And 3 months later, you have a sharply delineated ablation zone, and the patient remains seizure-free. So this is a way where we would have been hesitant to perform aggressive surgery, which we now can. And this is our algorithm in all of these focal lesional epilepsies, focal cortical dysplasias, tuberous sclerosis, heterotopias. We totally rely on the SEEG. We actually, and I'll show you examples where the imaging can be quite misleading and you think you have an FCD, but it's something else. Do a serial stereotactic biopsy to get a definitive histological diagnosis, and also do genome analysis. We then mostly, unless the lesion is too large, use laser now instead of an open resection. We perform post laser ablation MRIs, and then we go back and do a surface EEG immediately and see what happens. Electrophysiologically, we do a 24 and 3 month follow-up MRI. And this is a classical example. You see the movie running underneath. This is a patient who had actually two heterotopias. One very small one in the right lateral ventricle, and then in the posterior horn, a larger, very ellipsoid one. And what we did is we did an ECG study, and the patient clearly seized from both of these heterotopias. And we ablated both with a laser. And you can see this is the upper one, the ablation. You see the temperature on the left always, and the actual ablation. This is the voxels that reach 70 degrees Celsius, where you get immediate cell death. And this is a cortical dysplasia. You can see the laser fiber going in here, and you see the result of the ablation. And again, this is the way it was done. All these surgeries are carried out in the MRI scanner, actually. And the beauty is you see what you're doing whilst you're doing it, because you scan every 7 seconds and see how the lesion evolves. So you can stop it. And actually, more importantly, you can put temperature markers on sensitive, important areas that you absolutely want to spare. And the laser automatically will stop once it reaches a critical temperature there. The other thing, particularly with focal cortical dysplasias, this is another one here, which has, as you can see, a little streak going down to the ventricle, which is called the transmantle sign. And it's now quite well established. If you just treat the focal cortical dysplasia and leave this transmantle sign alone, you're risking that the patient's not going to become seizure-free. So you have to be aggressive and precise, put the laser fiber right down there. And you can see from the ablation on the right side here, the ablation went down all the way to the ventricle. So this is critical to bear in mind. This technology might look easy, but it has to be given a lot of attention and has to be used in a very precise fashion. And this is a case whilst we do biopsies, and this is actually a case again where the radiologist says, "Oh, this is again a frontal cortical dysplasia, quite clear." But the actual MR spectroscopy of this showed us a high choline peak, which was more indicative of a neoplastic lesion. And actually, we biopsied this patient as well, and it turned out it was not a cortical dysplasia, it was a ganglioglioma, which actually was more diffuse, and we performed an open resection, again, all the way down to the ventricle to prevent seizure spread from the epileptogenic zone created by the tumor. Another epilepsy that's quite interesting is the one created by cavernomas, where the pendulum is swinging. Cavernomas are benign vascular malformations. A lot of them, about 80 to 83%, are epileptogenic. And the old theory and party line was all you need to do is take out the cavernoma and the seizures will stop, so-called lesionectomy. That is all based on retrospective, not high quality data. And it turns out that, for example, in this patient here, where on the left, this patient had a resection already. You can see the section cavity, but still had seizures. And probably the surgeon stopped because what you see here in this color-coded greenish ray, that is actually the optic radiation, the optic pathway that using a special MRI technique called DTI, we superimposed there. So if you leave a little bit of hemosiderin, blood degradation products in the vicinity of these cavernomas, which they always have, you still can have seizures. And Bob Gross at Emory was the first one to show that actually you can very safely ablate these lesions with laser. And because of the precision of the laser, which is within a fraction of a millimeter, actually, if you look at the physiology, you can very safely do this close to eloquent structures. You've seen the ablation down here, the video. This is a post ablation, and we've actually spared the optic radiation. So this is what we do now. And interestingly, we have a huge national referral base for cavernomas and the optic radiation because we are the center of excellence for cavernomas at the University of Chicago, thanks to Dr. Awad. We always do our surgeries planned on DTI images of the optic radiation. Still, this can be tricky because you might have a cavernoma like here in the center, which is clearly in the primary visual cortex. So we've developed together with others actually an fMRI technique to map the visual cortex, which is topical to the retina. So different areas of your visual field can selectively be excited. And then we can assign different colors to that. And you can see the map where different areas of the visual field are. And luckily, this was not actually an active visual field, probably due to neuromodulation because the patient has this since birth. And this could then safely be ablated. And this is a pre and post outcome data showing a complete ablation of the cavernoma and the patient is seizure-free. And this is another one, just to illustrate the point, showing you the surgery again in the optic radiation, actually just above it, that could safely be ablated using this technique. And this is why we can do this so precisely. This is actually one of the first cases we've ever done because you might know laser ablation was actually invented for a specific very rare epilepsy, gelastic epilepsy and hypothalamic hamartomas. And we used other techniques before, interstitial radiosurgery, etc. And we were always very, very afraid because this is close to the brainstem, which is just behind the lesion, and the lesion is just below the optic chiasm. So if you make a tiny mistake, you can risk vision of the patient. And this is the first patient we ablated, and you can see how deep this lesion is. And the next slide shows you the actual result. What you can see is we ablated very nicely, the yellow zone, and you don't have to ablate every single piece of the hypothalamic hematoma. You just need to disconnect it from the brain. The problem is that right next to it is this structure here, looks like a boomerang. That is the chiasm. This is the most sensitive structure, which is very sensitive to both heat and radiation. And you can see this is our ablation. The dark spot is the laser fiber. You can see we basically encroached right up to the chiasm. We could do this because we've done numerous physiological studies looking at the border, the dose, the steep temperature drop at the edge of where we lesion. And we know that basically from a temperature that kills neurons and cells to no damage, we have a distance of 0.6 millimeters, which is basically a voxel in the MRI scan, one image point. And you can see you can very successfully in very critical areas close to the brainstem do these procedures now, which was unthinkable before. So that was the focal part. And now coming to LGS, actually, this is now, the rest of my talk is on generalized epilepsy, where we try to interrupt the epileptogenic networks or modulate the networks. This is not fundamentally new. The idea to just disrupt the network via a callosotomy, splitting the connection between the right and the left hemisphere via an open surgical approach. Our group actually published the first paper on doing this with a laser fiber, and actually 2 laser fibers. And what you can see is we introduced 2 laser fibers to disrupt the connection between the right and the left hemisphere. And in the middle, you see the diffusion image that shows the level of disconnection here. And this is the outcome. And one of our concerns was actually, because we did this predominantly in LGS patients, that we might not be able with these tiny laser fibers to ablate enough to have a good effect on the epilepsy. And that turned out to be wrong. As you can see from the diffusion images, we ablated more than 2/3 of the actual corpus callosum. This is pre, and this is post. This diffusion image, this means there is here, this part is completely disconnected. And what we also saw very quickly after the callosotomy, literally the next day, is this is a seizure sequence, this is an EEG, and this happens immediately after a callosotomy. So it is a very effective treatment, particularly for LGS. And then we actually, this is our first paper on the first 2 patients worldwide. You can see that the ablated versus the remnant part, we got a huge percentage of the corpus callosum ablated with these tiny laser fibers with a diameter of 1.6 millimeters, and sparing the patient the open craniotomy, the infection risk, etc. We now have long-term outcome data, and we've done 10 patients now. And you can see, this is another way of looking at it. We looked at the whole corpus callosum length and the ablation and the estimated disconnection. And you can see that you can get between 16 to 80% of the corpus callosum disconnected. That's all nice and beautiful, but that's all technology. What does it mean for the patients? And this is from our most recent paper on the 10 patients where we have long-term outcome data, except for one more than 12 months. And we got a very significant seizure reduction in these patients. And maybe even more importantly, because that really impairs the quality of life, the drop attacks. We got a enormous reduction. Some of these patients, actually 6 of them, 100% complete abolishment of the drop attacks, which of course was very much welcomed by our patients. Another way to disrupt the network, for which we now have very good biological rationale, is what was mentioned before by Dr. Salazar, is the deep brain stimulation. For that, we have good prospective data, the SANTI trial, and the current nucleus is the anterior nucleus of the thalamus. And this is one of our patients here, where you see the electrodes positioned on the CT scan. This is not a trivial surgery. For those of us who do stereotactic surgery, we can target those. We have atlases. This is not the problem. The problem is right underneath, it's hardly visible here, is what's called the mammillothalamic tract, which connects the hypothalamus, which is very important for regulatory purposes, including body temperature, etc. And if your electrode goes too deep and you stimulate that tract, the patient will have a lot of side effects. But it can clearly be done if you know what you're doing and if you're precise. And all our procedures actually are done with intra-op MRI or CT. So this is the original trial showing the basis for this. And what you can see, this is the long-term outcome data. You get, with these graphs going down, you get a significant reduction of seizures. And more importantly, over the years, and this is a 5-year outcome study, the effect actually increases. So it gets better every year. And whilst this was a clear experience already from the original data from the Velasco group in Mexico City, this paper from Brain shows exactly why this works. What they did in this group is they implanted the patients in the anterior nucleus of the thalamus, but also put depth electrodes in other parts of the brain. And then they looked what happened to the EEG in all these different areas off stimulation and on. And not much, except for exactly in the anterior nucleus of thalamus. If you stimulate there, the EEG gets silenced very nicely as a totally different pattern. More importantly, going to the network, showing how widespread the silencing is, they did resting state MRI and got this. What this shows is actually the connectivity of different areas of the brain, particularly the so-called default network that we've heard about before. And you can see that the connectivity is off and on, always goes down as soon as you turn the deep brain stimulator on, goes back and then down. So you get this clear pattern of connectivity density, which is reduced by the deep brain stimulation. Another way we've heard about this, which we're doing right now, is the RNS, which has the advantage that you're not continuously stimulating the brain, although we know that has a neuroplastic effect, knowing that over 5 years, the patients get better and better, but we're only stimulating when we can record seizures. And we prefer the central median nucleus because we did experimental studies and have recorded from this that even a patient with temporal lobe epilepsy has epileptogenic spikes and spikes spreading into the central median nucleus. And this system only stimulates when spikes are detected. Of course, technology is changing by the week. So the DBS system now also has this, a responsive stimulation, and we can also record from the areas in the thalamus as well. And we have currently a study ongoing, recording and stimulating from both the anterior nucleus of the thalamus and the central median nucleus. And both is very interesting and promising because this is going to be really physiologically based network modulation in individual patients. Another thing is that we went back to our temporal mesial epilepsy, and this also pertains to the network hypothesis, where if you look at the surgical literature, you can either follow the Penfield idea, the more you take out, the better it is, or you can follow the idea of Talleyrand, find the right focus and be precise. What turned out is if you look at the ablations of the hippocampus, size of ablation never matters. It is not an independent prognostic variable. So we went back and looked at all our laser ablations, and we've now done over 200 laser ablations, and looked and created these so-called heat maps here, where you can see red means actually a higher likelihood of an Engel class 1 outcome, means seizure-free. And what actually determines in this huge group of ablations whether the patient's becoming seizure-free or not. And it's actually if you ablate what's called the entorhinal cortex, which is one most important thing in the parahippocampal gyres. That's the outflow of the hippocampus. So if you don't get the whole hippocampus, that doesn't matter. You need to get the outflow that the seizures cannot spread anymore. And I'm coming to the end. This is taking it a little bit to the extreme using laser ablation. What we've done now in patients that have perinatal strokes and develop catastrophic epilepsy, the standard of care is a functional hemispherectomy, where you really completely disconnect the cortex on one side of the brain to stop the seizures. And now with our imaging of fiber tracts, we decided after the first patient was done worldwide at Boston Children's, we've done the second patient now, where we did not do any craniotomy, no open surgery, but implanted 5 laser fibers according to the tracts. And you can see these little orange dots here. This is the corticospinal tract, which is actually the motor fibers, which are targeted by this one laser fiber. And so just using these 5 fibers over a long distance, we could disconnect the whole hemisphere. And this patient was done 3 months ago. This is actually the actual surgery, and is completely seizure-free without any open brain surgery, just using laser fibers. We've seen that before. So this is the posterior splenium disconnection. So in summary, I've talked about this, but we want SEEG before we actually declare somebody as non-focal. We would always love to have tissue to look at molecular biology, but also to get a definitive diagnosis. And we use a lot of post-op surface EEG to look at the immediate results to look for independent prognostic variables. So this is our team, as you can see, in Chicago, a comprehensive epilepsy center, which means our pediatric epileptologist, the adult epileptologist, we are one group, one center. And as I'm board certified in pediatric neurosurgery and in adult, that comes in quite handy. So I think I've shown you what can be done with this technology. But I'd like to finish with LARP-XL, the other titan of neurosurgery. This is very powerful, very interesting if you use it based on the neurobiology, but it boils down to the simple sentence, fools with tools are still fools. So you need to be careful and make absolutely sure you have a good basis and a good hypothesis before you do anything to any patient's brain. Thank you.
Thank you so much, Dr. Warnke. Both your presentation and Dr. Burdette's have given a lot of information from a medical perspective, and it might take some folks some time to kind of really digest a lot of the great data you've shared. So now we're going to have a parent join us to kind of give her perspective. And there she is right there, Kim Kelsey. Thank you so much.
Hi, thank you for having me. Nearly 25 years ago, this rock, I don't know if you can see it with the sunlight, with this message was placed at our front door prior to us returning home from a 3.5-month long hospitalization for our son. It remains there, and it is my constant reminder. I will never leave any stone unturned. It's kind of heavy. It was early morning on Mother's Day, 1996, when we found our 4-year-old son, Alec, laying in his bed, lifeless, unconscious, not breathing, and near death. Frantically, we called 911. They arrived, immediately intubated him in our kitchen. The paramedics rushed him to our local hospital to try to stabilize him, which they could not. He was then airlifted by medevac to University of Chicago Weiler's Children's Hospital at the time, into the pediatric ICU. Alec was in a coma and on a ventilator for 18 days. And we were told multiple times that if he survives, we will never get our little boy back. His prognosis was extremely dire. We were given multiple EEG results every day. We would hear no significant brain activity, some brain activity, a bit more activity today, but not as much as yesterday. It was just a roller coaster. As I know many parents can associate with and feel, whether it's the medications or it's the seizures and the rest of it, it's a roller coaster that none of us wanted to have to ride. But we got him back. However, he was left with bilateral brain damage, cognitive challenges, permanent compromised lung function from aspirated pneumonia, neuropathy, and of course, why we're all here, epilepsy. Much later in our journey, we found out that his primary diagnosis was unspecified encephalitis with intractable or refractory epilepsy and at highest risk for SUDEP. Alec had defied all the odds, and I'm sorry, I'm kind of reading this, kind of trying not to, but it's hard because I don't want to miss any details. He defied all the odds that the physicians told us that he was up against. He literally had to relearn how to walk, talk, eat, swallow, breathe, everything. And following one of the many MRIs during the first month that we were in the hospital, a cyst was detected in his pineal gland of his brain. And now we were looking at brain surgery, unrelated to epilepsy and his seizures. Thankfully, a pediatric neurosurgeon was transferring to University of Chicago, Dr. Warnke's hospital, Dr. David Frim. And on his very first day, August 12th, 1996, Alec was Dr. Frim's very first patient at that hospital. And he successfully resected the cyst, and it was benign. So that was great news. But we still had the challenge of seizures and epilepsy. So it will be 25 years ago this Sunday on Mother's Day when our family began our epilepsy journey. I vividly remember sitting with my husband and a neurology nurse in a tiny conference room with 3 chairs. We were all squished together. We were going to be discharged after 3.5 months in the hospital. So she's going through meds, testing that we need to set up, physical, occupational therapies, etc. When she said to us, I will never forget this, epilepsy is really complicated and it's really tricky to treat. Sometimes something that works for one patient doesn't work for another. And sometimes it can take up to 2 years for the right combination and reach therapeutic levels. And all I remember is this voice in my head screaming, 2 years? It just seemed like eternity. And I thought, okay, here we go. Alec has come this far. We got him back. We're not stopping now. So we went from mom and dad to advocate, neurologist, pharmacist, lab tech, seizure specialist, physical and occupational therapist, and of course, staying true to leaving no stone unturned, research analyst. Alec has had tens of thousands of seizures in the last 25 years, rescue meds beyond, we lost track, many hospitalizations, 911 calls. Anyway, he has also tried and failed 24 plus anticonvulsants and drug combinations. One time we drove straight. People say, how far would you go? How far do you go to help your child, to help your loved one? And these are just a few examples of some of the typical things that we as parents try, and then some where you just go, why not? So we drove straight through to Michigan. I can't remember how many hours it was, but straight through to have a PET scan 20 some years ago when it was kind of newish, to have a renowned PET scan specialist read it and review it. We explored the VNS. However, for Alec, it didn't show enough promise for better seizure control in his case. We went through all the pre-surgical testing, the WADA test, everything to see if he would possibly be a surgical candidate, which at that time he wasn't. But honestly, after listening to the previous 2 doctors, with all of these lasers and not open surgeries, I have more research to do after listening to them. We also, if you could be a surgical candidate, we were all in. We looked into the ketogenic diet with a dietitian. And again, we were told that if it had any effect, it would be very minimal. And here's I call it Crazy Kim. A friend of ours told us about a healer that she knew that had helped so many people in his lifetime. So he lived in Canada. We live in Minnesota. We decided to drive straight through to Canada, 24-hour trip, in and out. Turns out we met a very nice man who wanted to help, but Alec wasn't healed. We were hopeful, but realistic. And then it was midnight in August of 2013, and I was flipping through channels. Came across a documentary by Dr. Sanjay Gupta called Lead Well. On the screen at that very moment, there was a young girl seizing and seizing and seizing, and my heart ached. My tears flowed like a waterfall, the helplessness, fear that we all feel for our loved ones as they seize, as minutes feel like hours, etc. As the documentary continued, I had this overwhelming feeling of hope that we all get, and we feel it. Sometimes it's quick, sometimes it stays with us. This was overwhelming. So I put on my researching hat and I dug in. And for 16 hours straight, from 16 hours straight until 4 p.m. the next day, our exploration into medical cannabis had begun. Unlike any other option that we had been presented, medical cannabis offered some life-changing upsides with virtually no downsides. And it was a plant derivative with no real negative side effects. So not trying it was not an option. However, it was illegal in Minnesota, and there was nowhere to get CBD oil that was regulated or tested unless we traveled to another state, which is illegal, and I would never risk that. So upon learning of the potential benefits of people with epilepsy, my hope grew and grew. I connected with leading scientists and advocates nationally to educate myself and find other caregivers in Minnesota to prepare to hit this head on. And we headed to the state legislature. We gathered as many passionate advocates, potential patients, hopeful moms and dads, families, met with countless representatives, senators, physicians, and pretty much anyone who would listen to our personal stories and our plea for a chance, because it might, just might, help one of our kids, help one of us, help one of our loved ones. So we attended every single hearing, press conference, testified countless times until finally and thankfully the bill passed. And I have to say, the crazy thing is, today was 7 years ago today that it passed in Minnesota. Right today. And then on July 1st at 12:01 a.m., our son Alec became the very first patient in Minnesota to receive this life-changing CBD medical cannabis oil. And medical cannabis has made an incredible impact on Alec's quality of life. He is so much more present, brighter eyes. I call them bright eyes anyway, but brighter eyes, greater level of awareness, tracking, more engaging, increased speed of his processing has drastically improved. He takes the medical cannabis CBD oil in addition to the 5 anticonvulsant meds that he's on. We know that he's not going to be the patient that can go off all his meds, and this is, the silver bullet. But the enhancement that it has given has been so significant. So the addition of his regulated and tested CBD oil has had 0 negative side effects and has really been a saving grace. It's not a cure. We had no idea if it would help at all. In fact, several people that we fought for it at the state capitol and the rest of it, and new patients that have come into it. Some it helps. It has healing properties, but there are patients that don't have any real impact, which is really hard. But with Alec, it has enhanced his quality of life. We have documented a measurable reduction in the number and frequency and severity of his seizures. Yes, Alec's seizures are still life-threatening. Yes, we are still at his side 24/7 for 25 years. But we believe his brain is healing, or it's helping it give it a rest on top of his other seizure meds. I guess the best way to say it is, we found hope in a bottle in addition to everything else. We won't stop, searching for something, as the other two doctors spoke about. And Alec will turn 30 years old this month. And 25 years ago, all odds were against it. He has always lived for and loved to play sports, and I'm proud and happy to share that over the past 20 years, Alec has been and continues to be a 7-sport athlete in the Special Olympics delegation that we started for him and 150 of his friends. So the hope of the mom is all I have, and I'll never, ever, ever leave any stone unturned. And we all have a story, and I just thank you so much for allowing us to share ours.
Thank you, Kim. What a heartfelt story, and congratulations to all of your success. Thanks for taking the time. It's so exciting that he's a 7-sport athlete. That's really incredible. That's really incredible. Give him a high five from all of us. That's really
I
wonderful.
will.
So now I know there are some questions in the queue, but we are just wanting to keep mindful of everyone's time. So we will answer those tomorrow in the open forum.